you can access some of our previous webinars. So if you'd like to go to and see the webinars that we've had before, you can go to YouTube and type IFC IQ Health. And there we have a retrospective of our previous webinars, at least some of them, I mean, the most popular ones. And we also have a broadcast of our today's webinar. So if you'd like to send a link to someone, you can do that. And that person can watch our today's webinar live. And that person can also look at the previous webinars that we had. Another resource that we've been using very actively is the IFC Healthcare Webinars page. So if you type in your browser IFC Healthcare Webinars, then the very first page that you're going to get is IQ Healthcare Webinars and Trainings, which is our main web page with all the previous webinars on healthcare quality that we had. So please keep that in mind. You can access our healthcare quality page. There is the same page also contains links to our online trainings that are located on the World Bank Group's training resource, OLC. And you can just type WBG OLC, which stands for World Bank Group Open Learning Campus, and you can access the webinars, you can access the trainings that we prepared for you on healthcare quality. Those trainings are free, they are self-paced, and they have certificates provided to you. That is how the page looks, where you can find the links to the training. So you press the link to the training that you want, and it takes you to the web page. And you have we have 10 trainings so far. For each of them, you can receive a certificate of attendance. Now, the main page that we use for our announcements and news is IFC Healthcare Tool page. And if you type IFC Healthcare Tool, this is where you will go to see all the broadcasts. You can see news, you can see announcements, and many other important things about healthcare quality. This is what IFC's team prepares for you. Now we go to some of the functions that you can use during our webinar. We have the interpretation button. You have it at the right bottom of your screen. If you press it, you have availability of different languages, and you can listen to the webinar in the language that you prefer. So we have simultaneous interpretation, and we do our best to catch everything that our speakers say in English. Now, a brief note to our speakers now. We have interpreters, simultaneous interpretation working. So we try to speak slower than usual so that our interpreters catch every word that you say. Okay, so this is another button that we have. And this is the button called, let me just move my screen. This is Q&A, questions and answers. If you have a question that you'd like our speakers to answer, you would open this, you would press this button, open this field and type your question. And that way the question stays there and we will pick it up and answer it either during the webinar or in our, or during our, or at a later time. Now we do have a community of practice where we have discussions and responses to our questions, and you will be getting a link together with after today's webinar. You'll be getting a link to that Facebook page that you can join. Now, another useful function is chat. This is where you can type everything else. You can introduce yourself, you can welcome other participants, you can share your opinion, which is not a question, just an opinion. We welcome any comments that you may have during the webinar, and this is where you put them. You press the button chat and you type your questions, or not questions, but you type your opinions, you type your notes, everything that you'd like others to see. Okay, now we are moving to the end of the webinar, and this is actually something new. So I want everyone that is listening, that has listened to me before, to basically listen now. Today's webinar is different. In fact, it's very, very different. We are awarding certificates of attendance this time. And there are two requirements to receive this certificate. Now, requirement number one is that you have to stay on the webinar for at least 60 minutes. I mean, if you disconnected and connected again, that we will add the time up. So it's not a problem if you had to disconnect, please connect back. And we will note that. But this is requirement number one, at least 60 minutes in this webinar. And requirement number two is on the screen. We want your survey on exit. So if you fill out the survey on exit, there will be a field where you will indicate the name, your name, as if you want it to appear on the certificate. So this is why filling the survey on exit for today's webinar is very, very important. It will only take 3 minutes. It's a very brief survey, but we need it to reconfirm your name on the certificate so that we don't go back and forth after the webinar asking to fill out another certificate or change the name or send you something else. So please do it at the survey on exit. You can also send an email to us to the address from where you received the invitation to this webinar, and we'll be happy to talk to you, to respond to you. We always respond pretty quickly, so this is another way of communication. But if you only send an email and you don't fill survey and exit, we won't be able to grant the certificate because those two things are intertwined. Okay, so this is the different thing about today's webinar. We are awarding certificates of attendance. And finally, it's a very different webinar. It's a very specific webinar. So I welcome today's speakers and I welcome Julia, who will take now over from me. Thank you, Julia.
Thank you very much, Natasha, for your wonderful introduction as always. Good afternoon, good morning, good evening, everyone. Welcome to IFC series of webinars. And today we are going to discuss a very interesting, very important, very specific topic. We're going to be talking about blood transfusions. So global statistics shows that a lot of mistakes and a lot of bad quality practices here in this area of blood transfusion relates to human errors. So it is especially important because the consequences of mistakes can be fatal for the patients. It is very important to create a robust system which would exclude the possibility of or minimize the possibility of these human errors. That's why we are going to discuss this today with our lab experts. And personally, I'm very excited. I think it's going to be very interesting discussion today. And I'm happy to introduce our first speaker. Many of you already know him. That's a member of our team, Manuel Giralda from Canada, a lab expert. Manuel, the floor is yours.
Thank you, Julia. Can you hear me? Can you see my slides?
Yes.
Okay, let me just.
And can you please go yes to the presentation mode?
Okay, yes. Good morning, good afternoon, good evening. Like Julia said, it's a pleasure for me to be with you today. And I'd like to start my presentation today by going straight to the final outcome, the final, hopefully, what we are looking at when we are transfusing patients. So we want to have the ultimate goal of transfusion medicine is to accomplish the 4 R's. And you can see, you have seen probably this in many, many books and many sources. So they're having the right blood type, the right patient, the right time, and the right place. Well, I want to provoke the audience by asking you these questions. What else would you add to the right? And you can type it on the chat while I show my next slide. You can type in your answer. What else would you add to this right time, right blood, right patient, and right patient? All right. So I have a couple of things that I like to add to that. The rights, I like to add the right amount. Well, instead of having 2, why not just 1 blood unit, right? The less that you do, the better for many, many, many reasons. And the second one is the right product. So you want to ensure that if you are doing instead of fresh fluorescent plasma, would you like to probably transfuse cryoprecipitate? Instead of having our whole blood, would you like to transfuse just RBCs concentrate? So I'm gonna move into the, like Julia said, this presentation will be a little bit of technical, but we have a couple of great panelists, and I'm very happy. I'm very pleased to be with both of them today discussing this very important topic that at the end of the day, what we're looking at saving lives and not having harm on those on patients. So my name is Manuel Giraldo. I've been working for the last 25 years. I've been working in Toronto in teaching in major hospitals in the GTA, in trauma hospitals. My last work was at community hospital, at North Yorkshire Hospital. It's an acute hospital, care hospital with more than 400 beds, 28,000 inpatients, 16,000 emergency visits, 31,000 surgeries, 6,000 babies are delivered annually at North Yorkshire General. And what we do is 1.8 million tests per year, 22,000 pathology cases, and we transfuse annually almost 5,000 RBC units. And I was, throughout my career, more than 35 years working in healthcare, I've been working as a lab scientist, manager, and director of pathology and lab medicine. So this is my team. Back in the day, just a team for transfusion medicine, and we won an award at that time for best practices and inventory management. So today, we're going to divide the presentation in three parts. My part, I'll be talking about the standards, guidelines and standards for transfusion medicine and blood banking. And then we're going to move into that through Titus. Titus is a physician who's in Nigeria. He's going to talk about his journey in terms of enhancing and improving his transfusion medicine services at his hospital. And then lastly, we're going to have Dr. Chihata Nadine, which I work with Nadine in many different cases, in many different settings. She is a hematologist at the transfusion medicine physician as well, who will talk about another components of the transfusion safety, the transfusion practices. So like I said, I'm gonna focus on the standards, and I will give you some tips as far as how to enhance your blood bank department. So when it comes to the standards, there are many standards available, and when you Google it, you'll find different organizations, bodies who have developed requirements and standards for blood banking and for transfusion medicine. One of the major ones that are very known are AABB. Then you have CSTM, which is the Canadian Society of Transfusion Medicine. The Z902 is also another standard, framework standard is used for transfusion medicine. You have ISBT, and then all of these standards are used by international accreditation bodies, by JCI, by UK, by Accreditation Canada. All these standards to accredit a hospital or transfusion medicine services. And then obviously you have the WHO guidelines as well. So we will, for the purpose of this particular webinar, I selected to talk about AABB standards. But before I do that, I'd like to bring to your attention a few interesting facts. Number one is that every 3 seconds, somewhere in the world, a person receives blood. And I picked these references from two renowned guidelines or bodies, WHO and the UK SHOT program, which is for reporting transfusion reactions. So every 3 seconds in the world, somebody's getting blood. Around 100, over 100,000, 100 million. Let me just lower my screen here because I can't see this, the red letters. Is over 100 million people donate blood globally, and 19% of those blood are collected in high-income countries, which makes around 20% of the world population. The next one is that low-income countries, most of the blood transfusions goes to pediatric patients, and whereas is the opposite in high-income countries, most of the transfusions will go to people over 65 years age. There are other interesting facts, and there are many, is that the blood donation rate in high-income countries is about 33 people donate blood for 1,000 people, whereas in low-income countries, only 5 people donate blood. So that obviously puts a strain on the healthcare system in low-income countries. There are many reasons why that happened, and maybe we'll see what Dr. Titus will tell us about that. And the last line that I have is that in UK in 2020, there were 7 ABO incompatible red cells transfusion. That sounds like low, but it's actually a lot, because that could end up in many detrimental bad outcomes for patients. And that amount of among over 1,000 near misses events in 2020, over almost 700 of them resulted from wrong blood in tube. And we're going to see a case of that, because this is one of the most common issues that happen when we in transfusion errors, in transfusion medicine errors. So from AABB, I pulled this slide just to show you quickly the steps. The process is a very complex process. Blood transfusion is a very complex process that starts from blood collection to going through all the way when after the blood is collected to and the blood is delivered or sent, shipped to hospitals or clinics, or in many occasions the same hospital will collect and transfuse the blood, will do the screening. So it's a very complex process that at any of these elements, any of these stops or components could something wrong could happen, and at the end, obviously, you could transfuse the wrong blood to a patient, or you could give more blood, or you could even give blood with an infectious disease as well if it's not done properly. So I start with the recruitment, then you do the screening to that patient. You want to make sure that it doesn't have a proper history, that hemoglobin levels, all the things that we do before we actually collect the blood. Then the blood is collected. I'm not going to stop individually because it will take us forever, but this is the major components. And then you do your screening. Again, it could be done in Canada and United States. These two components are done at a major center, centralized. So you have in Canada, you have CBS, Canadian Blood Services, will do the donor and the screening. And then they will always, they will also do the product, the irradiation if the blood needs to be irradiated. Some places will do irradiation, but most cases will be done at Canadian Blood Services. Then the blood product will be delivered, will be shipped to the hospital, and then we'll do an inventory management daily. People who are working blood bank will know what I'm talking about. And basically at that point, the physicians in that hospital, in that medical facility will make the decision, okay, we need to transfer this patient who come to, because there's a trauma in this case, a trauma case, we need to transfuse it, or we have a massive bleeder in labor and delivery, we need to transfuse this patient, or just simply because it's a patient with very low hemoglobin or platelets, whatever is the case. I'm talking about mainly about RBCs. Then the sample is taken, sample is sent to the lab will do compatibility testing. In other words, cross-matching testing will ensure that the blood, that the recipient will match the donor blood through a series of tests. We'll confirm the ABO typing on both sides. We'll do antibody screening to check for antibodies, irregular antibodies as well. And then the blood will be issued, whether it's a porter, whether it's the nurse or the physician who comes to pick up the blood, depending on where you are, because I know I've seen in many cases different people picking up the blood at the blood bank. Then you have to ensure that the blood is the right blood that you're giving to this person at this point. Then the blood will be taken to the floor, the ward, and it'll be given, administered by a nurse, by a physician, by a health provider to a patient. Before that happened, things will have to be confirmed. You have to do physical signings. You have to do the check temperature, blood pressure, or other things that you had to check there, and you had to confirm patient ID, and then you had to monitor the blood while the blood is being administered. And then you have the final outcome on this slide is that you had to have a lot of follow-up after that, and you have to discuss with your team blood utilization. And also there are things that happen like a look back. This is look back. For those who don't know what look back means, is that if you have transfused a patient today with an HIV negative, there could be a window period that the patient could become later positive for HIV, so that now you have to do a follow-up, a recall on that case, or even follow up on who was transfused with that blood. So that's very important as well on the change of the whole process of transfusion. The next slide that I have, just to show you that there are many steps, and we'll discuss it, but I just want you to focus on two critical points. Those are the blood sampling for transfusion, right? Before the specimen, before the blood is cross-matched, was tested in the lab, you had to get a sample. You had to get a sample from the recipient, tested, and things could happen if you don't get the right blood. The wrong blood could go into that tube, and then you could be doing the wrong testing for that case, and you could be issuing the wrong blood to the patient that is waiting for that blood. And at the same time, the prescription time and the administration is another critical point, because you have to check for two IDs, and you could have a patient in two patients in the same room with the same last name. So it's very important that we do two identifiers, and that's related to one of the major accreditation standards from JCI, from accreditation body, when it comes to patient identification. So for those who are more technical, like I said, I don't want to be in details, but I just wanted to know that those people who work in the lab and transfusion medicine, that is not only things related to pre-transfusion, errors could happen also while you're doing the testing. So look at these examples. The first one is obviously a pre-transfusion error that could happen if you mix up the blood in the wrong tube, or if you take the sample from the wrong patient. There's a WBIT, wrong blood in tube, excuse me. And then that's most of the issues happen because we don't have a strong policies and protocol, or we don't follow the policies and protocols, right? But then you have a few technical errors that are very technical. So I'm just gonna leave it on the slide. And those happen while you're doing the testing in the lab, not before, not after, in the lab. So just keep that in mind for those who work in transfusion medicine. Then I like to review this case with the team, with everybody on the audience. It is a case related to a patient that came to emergency department. She was admitted, 50 years old female. I'm gonna call it patient A. Her hemoglobin was 6.42 in American units. In Canadians will be 64.2. And then, or international units, I shall say, is 64.2. PT was 17 seconds, and fibrinogen 1.5. While the physician, after seeing these results, he ordered 2 units of fresh frozen plasma, 2 units of O positive red cells, and the patient was febrile soon after the administration started with severe rash. So the transfusion was terminated as a result of a transfusion reaction. What happened after investigating this case? This is a real case, by the way. It happens, it happens all the time, and it has been documented in many locations. Is the wrong patient in the wrong tube, right? And what happened is the patient, when the technician of the phlebotomist was to take the sample for cross-matching, they went to a room, and there were 2 patients with the same last name, same name by different last name. So they only asked the name. They didn't ask for the second identifier, date of birth, or not even they didn't ask for the last name. There were 2 people with in the same room, name, whatever is the name, but the last name was different. They didn't even ask for a second identifier, which is the date of birth. So it's very important that we keep that in mind. So obviously they picked the wrong person, O positive. They did the cross matching. They got from the fridge. They got no positive RBCs, and they issue it to the patient. The patient was transfused with O positive, which has natural antibodies for anti-A and anti-B, and the patient obviously has a major transfusion reaction right there. So the bottom line of this is that 50 to 70% of the errors happen in the pre-analytical stage. So many of those are related to incorrect ID, sample conditions, sample handling, or transportation. And there are 2 standards that I want to bring to your attention. One is from ISO 15189, which is almost the mother of all the standards in lab medicine. And it's about that you need to label those samples in a way that is unequivocal, in a way that is just unique for that patient, right? And the second standard I want to bring to your attention is from AABB. Is samples shall be identified with at least 2 identifiers. Just keep that in mind. We do that, but let's keep always that practice, and let's make sure that we have strong policies related to this. And then these standards are in line with major accreditation bodies around the world. So again, very important to develop strong policies and procedures and follow them and implement them and update those policies ideally once a year. So it's going to run to a few standards. The first one, we already saw it. The second one is that the person who labeled the tube should label the tube before leaving the room and beside the patient, right? The second one is that it needs to have the date and the time of collection and the individual that collected the sample so we can do a traceability. And then the third one is that the lab should develop policies to reject samples that are not accurate and not legible. So we need to develop those policies, especially for blood transfusion. This is a very important issue that happen if we don't have a strong policies in transfusion medicine. And then you want to have policies related to risk of misidentification in for patients. Then the next step, just quickly, just keep in mind that there are standards for the phase that you are preparing the blood before it's been transfused. You want to ensure that you have strong policies for your compatibility testing, cross matching, and you can see those on the screen. Those are very key components of the testing cycle before the patient receives the blood. And then the last piece is obviously the transfusion piece, the administration of the blood. And this part, you want to be in line with international guidelines. So you want to ensure that the blood unit that you are issuing is in line with international standards. So one standard we use worldwide is IBST 128. So I'm going to put that in on the screen. And then if you want, I can send you references on the site apart later on if you're interested in knowing more on this standard. But these are the basic components that you should include on your blood unit. And if you don't have a barcode system, then there are different ways to do that as well. Then you have then the administration piece is that you want to, during the administration, there are different devices that can be used, warmers, fusion devices, that if you have them, you have to have policies related to those. They have to have maintenance procedures, all the things that are related. And one key component that we must not forget, we shall not forget, is that before transfusing, we have to explain, physician will have to explain the patient the benefits, the risk, and the alternatives for transfusion. And they have to sign off an informed consent for blood transfusion. And after issuing and before transfusing the patient, the nurse or the provider will have to confirm those 5 key points that I have on my screen, right? So this is the key during that process, confirming the name, the hospital ID, and asking the patient for their name and the date of birth. Instead of calling them by name, ask them to state the name if it's possible, where possible. Obviously, you can't do that if it's a trauma case, if a patient is unconscious. Now, lastly, I think this is my last slide, is that you must report, evaluate, investigate incidents. And on the right hand, I have a form, a printed form of how you can report transfusion reactions incidents. There's a lot of investigation that has to be done for the blood that was transfused, for many components, check if the vital signs were checked, all the things that had to be done in the lab, the sample has to be again checked, again, to learn from those mistakes and to prevent occurrence of happening again. So we must report, and this is something that we must stress in our organizations, that any incident, whether it's mild or severe or sentinel event, should be reported so we can track it, we can learn, and we can monitor if we are improving with the time, right? So we must have those policies available. And the last component is about transfusion medicine committee, and this is something that Titus and Nadine will discuss in length, is the importance of having within the organization a multidisciplinary committee with representations from key stakeholders from the lab and from clinicians and nurses who can help you to monitor best practices, educate, and develop policies as well. So lessons learned: avoid unnecessary and inappropriate transfusion. And I quoted here in brackets, choosing wisely. This is an international campaign already implemented in over 35 countries, and some of those recommendations about choosing wisely or doing the right thing, doing the right treatment, procedures, and medications is about transfusion medicine. So I invite you to start looking into this website, Choosing Wisely, and learn from transfusion medicine what can be done to reduce unnecessary transfusions in patients. And then the next one is obviously, like I said, develop your very good policies and procedures in blood bank and transfusion medicine. Make sure to update it and use international guidelines from WHO, for ABB, CAP, or from major accreditation bodies in the world, like JCI, Accreditation Canada, UK, Australia. Establish a multidisciplinary transfusion medicine committee. Provide training to your staff. Do a competency assessment. Check if the people who are doing transfusion medicine are competent on an ongoing basis. Engage your staff on QA activities. And many places, I think Nadine will talk about the transfusion safety officers. So we're going to let that for Nadine. And then ensure that your people in your place have a continually quality improvement mindset to investigate and to learn and use evidence-based tools such as root cause analysis of fish bones diagrams here to do your investigation of those cases of transfusion reactions. And lastly, make sure to evaluate your system periodically to check if your system is effective. So thank you very much. I think this is all for now. I'll be happy to take some questions at the end. Back to Julia.
Thank you very much, Manuel. By the way, thanks a lot to our audience for being so active today. When we mentioned the name of our webinar, Right Patient, Right Time, Right Place, actually we received lots of responses. How many other things should also be right? So obviously this topic is very important, and lots of questions we already receive from our audience. So we believe that this will be a useful exercise. And one technical point that we wanted to make, because it's such an important topic today, we had extremely high attendance, and Zoom only allowed 500 participants to join. So others who wanted also to listen and to participate in this discussion had to be transferred to our live streaming on YouTube. But don't worry, those who are watching us on YouTube today live, that's important point. Those who are watching us live will also get the certificates that we promised, the certificates of attendance, certificates of participation. But for this purpose, we will need from you to send your name to the email. You can just respond to IFC email that you received invitation from, or you can use IFC Healthcare email as well if you already used it. So please email us and make sure, and we will make sure that you will get your certificates. Please do not worry. But this is important for those who are watching it live. I'm repeating it, it's an important point. So now we move to our next speaker today. That's Dr. Titus Agundare, the chairman of the Transfusion Medicine Committee from Nigeria. And this is a real life story. Okay, Dr. Titus, the floor is yours.
Thank you. Good morning, everyone, or good afternoon, everyone. It is afternoon in Nigeria. And Julia, thank you so much. Manuel, thank you so much. And I thank all my audience that they're online. And I'll also take this time out to thank the management, the medical directors of Harrow Jolat for giving me this opportunity, Dr. Funsho Ladipo and Dr. Abiola Fashional, an emergency physician, for this golden opportunity. And this afternoon, as part of our webinar today, I will take us through the blood transfusion practices at Harrow Jolat Hospital, Lagos, and the emphasis will be on the journey so far in the prevention of blood transfusion error. Here are my outlines. I will quickly talk about the historical background of Harold Jollard. I'll talk briefly about myself. When did we start blood transfusion services at Harold Jollard? Where we are today, the source of blood transfusion errors and their prevention. And also, I'll make mention of the trend of blood usage at Harold Jollard, incident reporting, then I will conclude. By way of history, the hospital was established by Dr. Funsho Ladipo in April 1982 in a story building. And as we can all see in the other slide beside, now we have a 5-story building that was launched earlier this year. That means it could infer that we are moving a story per a decade. And I'm also happy to tell you that we also have about 4 other branches to Harold Jollard. So Harold Jollard Hospital is in existence for over 41 years and it is moving forward. However, there was no laboratory services at inception. The hospital largely depended on a private laboratory called the Main Top Laboratory that is located 300 meters away from Harold Jollard. So this is also by way of history, seeing at some point, there was no laboratory scientist. At some other point, and in 1985, it was just a site laboratory that was set up where rapid tests were conducted. In 3 years later, the site laboratory had only 1 laboratory scientist that manned the place, and this grew to 4 laboratory scientists, 4 laboratory technicians, and 1 support staff in 1988. However, we didn't start blood transfusion services until 2008. We made an application that was in 2007, 11 months after the Lagos State government gave us approval to commence blood transfusion services. And on to date, we've been doing very, very well when it comes to blood transfusion and medicine. So this is the briefing about me. I'm a fellow of Medical College of Anesthesia. A fellow of the Medical College of Anesthesia. I am the current head of the Department of Anesthesia Services at Harold Jollard, and I have over 9 years working experience of delivering safe and uncomplicated anesthesia to all categories of patients, be it neonate, be it elderly, all categories of patients. And I'm also a very passionate manager of critically ill patients. For my passion for critical care, I developed critical care outreach team at Harold Jollard. That was upon my appointment 18 months ago. And the core services include the institution of central venous cannulation. I have done well over 1,003 central lines with 5 reported cases of pneumothorax. And I use simply landmark approach without ultrasound. Someone may ask that why are you not using ultrasound since it is internationally acceptable, but then sometimes you may be called upon that you come and set a central line for a patient that need inotropic support in one hospital and you are not with your ultrasound. Then it is very, very important for a full-time clinician to learn the use of landmark approach in instituting and central venous cannulation. It is very important for you to know that I also engage in a critical care transport locally. That is, critical care transport means that I engage, not minding my status, the inter-hospital transfer of critically ill patients. Maybe there is a patient that we cannot manage in our hospital, then I can move the patient to a higher hospital where the patient can receive a better treatment. And also I also engage in interstate movement of patients, as in on land and also in the air. So, and I've done well over 53 in the last 2 years. It is very important for you to know that I engage in palliative care medicine, that is managing of chronic pain in cancer patients or other related. And lastly, it's very important for you to know that I'm American Heart Association certified when it comes to in the area of cardiopulmonary resuscitation. So this critical care outreach team gave birth to a critical care unit, that is the ICU 6 months ago at Harold Jollard Hospital, and I am appointed as the pioneer director by the emergency physician, Dr. Abiola Fashion and Dr. Funsho Ladipo, to lead the team. and also engage in further training of diplomate anesthetists in the area of airway management. This is attempts to complement the safe discharge of their clinical duties. I have been able to pioneer the development of conscious sedation outside the operating room. That is, if a patient, an autistic child or patient with disability is coming for a CT scan, is coming for endoscopy, then I get invitation from the radiological team to give the patient conscious sedation so that they can actually rely, because as we all know, children with autism, children with Down syndrome, they don't get to relax for procedures. And also patients with head injuries are engaging in all of this. And also very important, labor epidural anesthesia services. I started this one 18 months ago at Harjolat. Since about 4 months ago, following the resignation of my predecessor, Dr. Payemi Bashir Lawan, and I was appointed as the chairman of Blood Transfusion Committee, and I can tell you, with the aid of, with the help of Manuel and the IFC group, the work is in progress. See, here are my team members. See, we are much than this. We're about, we are well over 10, but then these are the few that were available at the time we took this picture. And this here are our activities. As I said earlier, we're about 17 in the blood transfusion committee at Harjolat. We meet once a month and usually second Wednesdays every month. Here also our topics that whenever we meet, this is what we, among other things, that we try to talk about when it comes to blood transfusion committee. As you know, we were inaugurated last year, October, and as we speak, we are getting better by the day. So let's come to the meat of the matter. Saying, when did we start blood transfusion at Harjolat? As I said earlier, we're giving approval. That was in 2008 by the Lagos State government. So by the Lagos State government, and at inception, we were only limited by a refrigerator that was 50 pints of blood, and the hospital was limited in transfusion services, as only family replacement was the source of blood donation. Hence, the hospital relies so much on external blood bank services to meet up with demand. So where are we today? No doubt, a lot of improvement with acquisition of Harjolat by Afia Group in 2019. That has been a tremendous improvement in blood transfusion services. And we have moved from 50 unit refrigerator to 250 capacity refrigerator. And here is the source of our source of blood donation. Usually in voluntary donors, we have just about an average of 7 donors per month. Sometimes we could get 10, sometimes we get 5, but on the average, we get 7 donors that will come into walk into the hospital to donate freely without any financial benefit. However, to walk-in donor, we only have one in 6 months. We should all know that a walk-in donor is actually very obsolete, and it has been highly criticized by Lagos State government blood transfusion services, because as we speak in Lagos State, any blood we are getting must come from the central lab. But sometimes when we are short of blood and we are in the face of emergency, we may actually try to screen the father or the mother of a child so that there is no delay in giving blood to that child, because blood, as we all know, saves lives. So more importantly, our major source of blood is blood donation drive. This blood donation drive, we do it twice a month, and on the average, we get the minimum of 40 units of blood per drive. So here is the blood donation drive. Is a 2020 initiative at Harjolat, and the aim of it, is to meet up with hospital demand. because seeing 7 donors a month cannot actually meet up with Arjola. As we all know, Arjola is a general hospital in Baghdad, Lagos, and also to commercialize Arjola blood banking services. As I said earlier, it is done twice a month, excluding the fasting and the festive period. Average unit of blood generated per drive is 40 units, and it's important for us to know that we can get as much as 60, 70 per drive. So we're in collaboration with some other hospitals, such as Reddington Hospital, Eco Hospital, Afolabi Medical Center, and to mention just a few. And the essence of it is that once we have excess blood in our blood bank, so we give it out so that we don't want blood wastage. And sometimes when we are in shortage of blood, we also consult them to get blood to give to our patient. And more so, we also in alliance with some tertiary institutions and around Lagos. I'm talking about Lagos Highland Maternity. I'm talking about the prestigious Lagos University Teaching Hospital and the Lagos State University Teaching Hospital, LASUT. Here is our blood usage from January to June 2023 at Harrow. As we can see, from January to June, the data being collected from our blood bank services at Harrow show that the least unit of blood that was transfused to patient was 40 units of blood. You can see in January, and as opposed to May, where we have the highest, which is about 83 units of blood. 83 units of blood was transfused was given out from the blood bank. So you can see, if we rely solely on voluntary donors, it is unlikely, very, very unlikely that Arjola will be meeting up with blood transfusion at Arjola. So we have to give kudos to the team that engage in this blood donation drive. So you can see, if we have 40 per drive, and we do it twice a month, that is about 80, minimum of 80. Then if we have, that means with 83, that means we still have to rely on external lab to get more blood. So here is one blood donation drive in one of the university in Lagos, University of Lagos. So the essence of this video is to tell us that this is actually not too good enough, because there is a multiple bleeding per time. There is multiple bleeding per time, which needs to be corrected. So here are the sources of blood transfusion error at Harrow. Sometimes we label samples in advance. Then mislabeled sample is sent to the lab, as Manuel had just said the other time. Improper identification of patients when you don't identify your patient very well, and administration error, incorrect blood type. Maybe a patient is given AB blood group to O blood group. So this one can cause some level of agglutination. And it's very, very important for us to know that blood transfusion negligence is common around us here, because sometimes when we are giving blood to children, we actually give blood for blood. And most of the time we don't use the blood bag to transfuse blood in children. We use syringes, and in fact, we have formula that we use in children. There is inappropriate storage temperature. As you saw in that video, saying it's very unlikely, if you spend like 3 or 4 hours at the blood donation site, before you get to Harrow, it may take about 6-7 hours. And believe you me, you can actually, the platelet can get donation before you get to Harrow. And also too, transport of blood and blood products is very, very important. Most of the time, if you're in the traffic, because Lagos is actually a very traffic-ridden state, then before you get from the point you are picking the blood to the hospital, the receiving hospital, saying nobody knows the time. So, and most of the time, the cold chain is actually breached. So it is very, very important for us to know that all these ones causes some level of blood transfusion errors. Saying how then do we prevent? We have to avoid clerical errors, ensure accurate patient identity during labeling of sample and completion of request on an electronic medical record. We have to bleed one patient at a time to reduce identification error. We do not need to label sample bottle in advance of sample collection. You have to collect the sample, then you label. We have to maintain cold chain during transport, avoid over-transfusion in children. 2 clinical staff must cross-check blood bag and tally before transfusion. And most importantly, then we have to develop and implement strong policies and procedures, that is, stand SOPs that are in line of blood transfusion medicine. This one we have started, but we are getting better by the day. Here are the limitations of blood bank services at Harrow-Jollard. It is important for you to know that we are limited to processing only whole blood at Harrow-Jollard. We do not have the capacity to process blood products. By blood products, I'm actually talking about packed cells, talking about fresh frozen plasma, cryoprecipitate, and others. So as it stands, we still rely on tertiary institutions, that is the prestigious Lagos University Teaching Hospital, Lagos the Island Maternity, and these are the tertiary institutions in Lagos where we get our blood products from. And it's still very unfortunate that when I went through the documentation we have in the blood bank, there was no documentation of blood bank received from all these institutions. This is deeply abysmal. But then, with this current blood transfusion committee, we're going to improve and ensure this thing is a thing of the past. So in incident reporting, there are 3 cases of reported blood transfusion reaction since inauguration of blood transfusion committee at Harrow-Jollard. That was last year, October. So from then to now, we have recorded 3 cases of blood transfusion reaction, and 2 out of the 3 cases were due to ABO incompatibility, and 1 of them was actually due to massive blood transfusion reaction. So currently, the hospital management led by Dr. Funshaw, Ladipo, and Dr. Fashino, they've been encouraging all clinical staff to report any kind of error or near misses so that everyone could learn from them. So in conclusion, it is important for us to know that ABO incompatibility is a never event because it can lead to the demise of the patient. So, and as such, at least 2 hospital staff should cross-check a blood unit before its administration to recipients. With the guidance of International Finance Corporation Healthcare, we, the current executive of Blood Transfusion Committee, Harrow-Jollard chapter, hope to do more in terms of donor-recipient compatibility, reporting of complications of blood transfusion, and documentation of blood products received from outside blood bank. And lastly, we should know that we don't learn from talking, we learn from listening. Thank you for your rapt attention.
Thank you so much, Doctor. Thanks a lot for sharing your interesting story, and special thank you for sharing the practical tips, which I think I found very useful. And considering the fact that the slides will be shared after this event with every one of you, actually, you can print it out and just use these rules in your lab. Just all the tips and all the practical solutions that Dr. Titus just shared with you. And also, it's very important that Dr. Titus stressed the 2 key components that you need to start with talking about safety of blood transfusion. That's the blood transfusion committee and the incident reporting. So these are very interrelated components, but they are significantly improving the safety of in this very critical area. So thank you very much. And thanks a lot to the audience for sending your questions so actively, both in the chat and in the question and answer section. Please continue doing that. We notice all the questions and we also received some in advance. and we will address all of them, most of them, during the question and answer session. And now our third speaker, Dr. Nadine Shehata, the Medical Director of Transfusion Medical Laboratory from Canada. Dr. Nadine, over to you.
Yes, thank you. Good day, everyone. I'd like to thank Manuel and all the members of the IFC for inviting me today to give this presentation. And I've used a similar title as was given to this entire webinar, The Right Product, Right Patient, Right Time. And before I get started, I was going to pose a question sort of similar to Manuel and ask, what do you think is the most common adversity from transfusion? Please feel free to use the chat or just think about what you consider the most common adversity from transfusion. So I'm going to answer that question. And really, the most common complications of transfusion result from transfusion errors. I have two objectives for the next 20 minutes or so. For you to appreciate the potential for harm from transfusion errors, and to explore the development of preventive and corrective actions to reduce the risk of these transfusion errors overall. Deaths from medical errors are higher currently than deaths from motor vehicle accidents. And that is because, as Manuel and Titus had actually discussed, the transfusion system is quite complex. And what you're seeing on the graph on this page is essentially on the horizontal axis, the frequency, and then the types of deaths, some of them related to transfusion and some of them not related to transfusion. In most high-resource countries currently, the risk of death from transfusion-associated HIV or hepatitis C is really, really small at this point in time. However, deaths from medical errors are quite frequent, and more frequent, as you can see, than deaths from motor vehicle accidents, deaths from delayed type hemolytic transfusion reactions, and acute hemolytic transfusion reactions. I've highlighted below death from medical errors the deaths from TACO, which is transfusion-associated circulatory overload, and I'm going to consider that as a death from medical error. The types of errors have been highlighted as well in the prior presentations, but I'm just going to go over them as well in terms of what kind of errors can occur. And this is more at the hospital level as opposed to a donor center level. As you can see here, it can occur at the level of product requests. So for instance, ordering blood incorrectly for the wrong patient. At the level of sample collection, for instance, the sample labeled with the wrong patient identification, or it's not labeled at all, or the wrong patient is collected, or the label is ineligible, or the armband is incorrect. At the level of sample handling, for instance, paperwork usually goes with the sample, and in this situation, the paperwork and sample ID don't match. At the sample receipt in the laboratory where the sample is accepted in error, or it's incorrectly labeled with an accession label, or the sample and tubes end up being mixed up or mislabeled. The request for pickup can also result in error if it's picked up for the wrong patient. And the unit issued can be issued incorrectly to a patient, or the wrong type or dose of a product is issued. And lastly, the unit transfusion, it can be administered to the wrong patient. If we look at all these types of errors, the most frequent errors are going to be at the level of sample collection, sample handling, and unit transfusion. But I would consider that errors can also occur, right, and I think Manuel alluded to this as well, is at the patient level from the perspective of, did this patient require the blood transfusion? So take the following case scenario. This is a 75-year-old female who had inflammatory bowel disease, Crohn's disease. She'd had ongoing recurrent gastrointestinal bleeding, and she comes to an emergency department with fatigue predominantly as her symptom, not so much the bleeding. Her ferritin is less than 5. Her hemoglobin is 90. However, she's hemodynamically stable. 2 units of red cells were requested for her, and not surprisingly, within 4 hours, she developed severe dyspnea, hypoxia, her temperature is 39 degrees, and she needs critical care support. This could have potentially been avoidable. So that if we look at it from the perspective, starting from the patient and going to the laboratory, and also donor centers as well, the transfusion medicine infrastructure is complex. And from my perspective, there are 3 principles that guide the development or the need of a transfusion infrastructure at the hospital level. That would be leadership, education, and errors are going to occur, but ensuring that when there's corrective action, because these tend to be system problems, that it's non-punitive and preventative. From the perspective of leadership, that leadership is there not to tell people, but to engage. It's as Titus mentioned in his last slide, essentially, it's listening and encouraging engagement from the entire hospital. So team building and that communication aspect is integral to that team building aspect. Education should be accessible as well as self-explanatory. So in situations of need, then each individual that is part of that transfusion infrastructure knows what the steps are going to be. That transfusion leadership can be categorized into the transfusion medicine committee and the transfusion medicine laboratory or blood bank. Predominantly, we're moving away from the term blood bank just because it's not people just giving blood, that it's the transfusion medicine laboratory who's involved in the transfusion medicine decision-making, and both the transfusion medicine committee and the transfusion medicine laboratory are there to promote or to target best practices. The transfusion medicine committee essentially is going to represent the hospital. So any service that transfuses should have a member on the transfusion medicine committee, again, so that their voice with regarding transfusion is heard. Should it include someone who's looking at quality systems for the hospital, nursing, because they are integral, obviously, to transfusion, and obviously someone from the laboratory. So all services should be involved. There should be a chair of the committee, and I've indicated that ideally it should be a rotating chair. So essentially, what is a rotating chair? That the chair is selected from each one of the services to give them the knowledge, for instance, anesthesia or surgery, about transfusion. So again, they can disseminate transfusion knowledge to their services. Following that, any output from the transfusion medicine committee should be minuted and taken up to the highest level of the hospital. At our hospital, that's called the medical advisory committee. So again, that all services and all chairs of all services are aware of transfusion medicine decision-making. It is the transfusion medicine committee in targeting the best practices, in providing education to the hospital, needs to be directive about when and when not to transfuse. So for instance, if at a hospital, the means of indicating a transfusion is on a sheet to say transfuse 1 unit or transfuse 2 units, as an example, pre-developed transfusion orders can be used as a means of educating and as a means of reducing transfusion errors. So for example, if on a sheet that is given to an individual to order a transfusion, the following is indicated, perhaps that could also reduce transfusions given when they're not supposed to be given, and ensuring the appropriate rates and the appropriate amount of transfusion overall. So for instance, this is from our hospital. When it comes to transfusion, the physician is asked, is the transfusion history known and documented? Has the individual received a previous transfusion? If it's a female, is there a previous pregnancy history? Do you know what the individual's volume status is? So this patient that I had described was 75 years old. The likelihood that she could actually tolerate large volume was low. So in that situation, are diuretics ordered, or are you planning to order them? Information about dosing, that each unit of red cells, for instance, has 290 mils as a volume. And if you're giving 2 units, that's approximately 600 mils. That's a lot of volume. Be prepared for it. that each unit will increase the hemoglobin concentration by 10 grams per liter, for instance, so that the individual who's ordering is aware of what they are going to be expecting from a unit and may not then prescribe the 2 units. As Manuel had also discussed, choosing wisely, transfuse 1 unit instead of 2 units. That transfusion order can be even more detailed by listing the indications for the prescriber when and when not to transfuse. And lastly, as you see on the bottom of this slide, is the red cell transfusion should not be administered for iron deficiency. So very clear-cut guidelines can be given to a hospital easily on a prescribing form. So going back to this patient, she was 75 years old, likely not able to tolerate a lot of volume. She was stable, however. Her ferritin was low. She was iron deficient, and treatment of iron deficiency is iron, not red cell transfusion. Her hemoglobin was high, yet she received not 1, but 2 units over 3 hours, and obviously then developed side effects from the transfusion that was given. And again, that level of error or level of education starts from the patient onwards. If this patient, however, had come into the hospital, for instance, and was massively bleeding, then it's completely different, because then it's a lot of other members of the hospital need to be informed about how to manage a massively bleeding patient. In our hospital, when it's a massive bleeding patient, that is called a code omega, for example, and we have posters in the hospital in all places where massive bleeding can occur, for instance, in labor and delivery for obstetrics, in surgery, in the emergency department are major areas where we have massively bleeding patients. Posters are put up with criteria for each individual involved in that resuscitation process about what they're supposed to be doing. For instance, what does the blood bank need to do? What does paging need to do? What should the clinical response be in terms of the type of tubes that are collected for blood? What should the porter be doing each step of the way? And what happens with overhead paging to ensure that when resuscitation occurs of a massively bleeding patient, it's done appropriately and that we reduce the risk of errors overall. Now, not only is the Transfusion Medicine Committee, from my perspective, responsible for best practices in education, but I think more and more it is the laboratory or the transfusion medicine laboratory technologists or scientists that are also responsible for best practices. And it's a technologist needs to be in charge of transfusion. And that's very easy when it comes to a hospital that's transfusing a lot of blood products that can designate one individual to being in charge. But that may not necessarily be the ideal for a lot of hospitals that don't have a lot of technologists in the laboratory. As long as one individual is assigned with being responsible for transfusion education, I think that also serves the purpose of ensuring that, that the lab is going to be focused on quality and production. There still should be a reporting system for the laboratory to the chief of pathology. Again, an overview to ensure that from a laboratory perspective, quality metrics are being followed. The responsibilities of the transfusion medicine laboratory include the development of standard operating procedures, and I think Manuel also alluded to this. Standard operating procedures are stepwise, detailed instructions for all transfusion-related processes. It's to ensure, for instance, at night, when there aren't many people around, that if there's a transfusion that comes in or a transfusion-related problem that comes in, an individual can go back, find a procedure that's been written down that follows standard criteria to ensure that that transfusion goes to the appropriate individual. That stepwise detailed instruction, or the SOPs, are required at the level of instrumentation, product indication, specimen collection and labeling, testing, and how to transfuse. I've shown you an example here of a stepwise detailed instruction for instrumentation. So for instance, for centrifugation, every program is listed, the speeds are listed, and what transpires with each of those. for product indication, not only is it on the order sheet for prescribing physician, but also at the level of the laboratory, that they're looking at lab work as well, so that they can advise physicians to say, for instance, red cells are not advised for anemia secondary to iron deficiency. At the level of specimen collection and labeling, as was mentioned in the previous presentations, patients must be positively identified using 2 identifiers and compared to the specimen's labels before drawing blood at the bedside. And then 2 healthcare providers are required to identify the patient. That is all written down in a standard operating procedure. An example of testing, for instance, if you're looking at group and screen or alloantibody development, detailed instructions about what is done. So for instance, number 1 here, wash the red cells to be used for titration 3 times. It's that degree of detail that's required in a standard operating procedure. And lastly, how to transfuse. For instance, this is on the bottom of the slide here. Oops, excuse me. That how fast the transfusion should run slowly in the first phases to reduce the risk of transfusion reactions. The transfusion medicine laboratory or transfusion medicine service, depending on the hospital, also should provide education, and again, education that's going to be accessible. So for instance, for the wards or for hospital staff, pamphlets can be developed and left on the wards so that if individuals have questions about transfusion, they can easily have a paper document that they can review. It doesn't necessarily need to be web-based. If you have access to an intranet or intranet, that's great to post them there. But if not, paper documents can also be used, highlighting aspects of transfusion such as informed consent, what's required for pre-transfusion testing, and what happens what transpires when a sample is rejected. Sometimes information is required much more rapidly than that. So lanyards can be used, for instance, where it's hung on a collar, for instance. What happens in a massive transfusion? You can look at it, and on the back of that, for instance, this is what we have at our hospital. In a transfusion reaction, this is what you should be assessing, and this is what you should be doing. So there are means of ensuring that safe transfusions can be administered. Education is required in an ongoing means. Maintaining educational competence is the responsibility of both the Transfusion Medicine Committee as well as the Transfusion Medicine Service or Laboratory. Learning modules should be developed, from my perspective. At our hospital, we have learning modules for nursing, for physicians, and now for porters who are transporting blood back and forth to ensure that transfusion medicine knowledge is maintained over time. For the laboratory or for our scientists, proficiency testing and test performance is actually done more frequently than yearly. And periodic audits are also done to ensure that what we are thinking we're teaching the hospital staff and laboratory is actually being done. Lastly, is really engaging patients. So empowering patients about transfusion overall. We have transfusion information, brochures for these patients when they're receiving the transfusion to ensure that they understand the rationale for the need of blood, as well as brochures to tell them this is what to expect if you are sent home from hospital after transfusion to reduce the risk of a severe adverse event after transfusion. Okay, when it comes to the transfusion medicine laboratory and the transfusion medicine service, sometimes they can be seen as distinct entities. Someone's in charge of the lab, someone is in charge of the clinical service. The transfusion safety officer is a role that has been embraced by many hospitals. And the intent of a transfusion safety officer is really to ensure that the hospital meets the standards for patient care. The transfusion safety officer is the collaborator, communicator, ensuring that everyone is on the same plate, essentially. This can be a technologist or a nurse. It may not be, a hospital may not be able to assign a full-time position for transfusion safety officer, but it can be assigned sort of as 25% of someone's time from nursing or from the laboratory overall. The transfusion safety officer is responsible for education, for consultation, to ensure patient safety by auditing transfusions in the lab as well as on the ward, by investigating unsafe work practices on clinical wards and in the laboratory. Essentially, their responsibility is the quality of care. So I discussed from my perspective that there are 3 principles for developing a transfusion medicine infrastructure: leadership, education, and the last to discuss is really that corrective action when an error does occur. Corrective actions, and I will emphasize this, really should not be punitive. It is a system problem, not an individual problem. And that corrective action plan requires assessment by direct observation, monitoring, and reassessment. That direct observation, for instance, if it happens at the bedside where there's an error, then it's routine patient identification performance. If it's in the lab, for instance, for instrumentation, then again, it's laboratory performance, looking at instrumentation maintenance. If it's a monitoring, then ensuring that, for instance, results are recorded properly or reported properly as well. And lastly, it's reassessment. Relook at the whole situation from the perspective of ensuring that test performance has been done adequately. And if not, then repeat test performance by, for instance, external proficiency testing. The bottom line really is to ensure that there's a problem-solving means to assess any situation to reduce the risk of the error occurring again. So I will stop there, and my take-home points really are: transfusion errors are the most common cause of transfusion-related morbidity. The pathway of blood delivery, it's complex, and there are multiple patient care areas involved. Really, systems need to be developed to navigate this complexity that include leadership, education, and corrective action that is non-punitive. Thank you for your attention, and I'm happy to take any questions.
Thank you so much, Nadine, for sharing this wonderful presentation. And just to sum it up, I also wanted once again to draw your attention to the wonderful examples of flowcharts that Nadine shared. Once you receive the slides, you can have a closer look at them, and hopefully you will find them inspiring and develop your own flowcharts, because just again, to use this as a conclusion, the key components of safe blood transfusion are the blood transfusion committee, the blood transfusion officer, standard operating procedures and clear instructions and guidelines and flowcharts, and also non-punitive culture, which helps you to effectively use the incident reporting system when everyone is open and transparent, discussing everything that went not as it was expected to, any mistakes, any abnormalities, you should discuss together as a team and find a solution together as well. Before we move to our question and answer session, I also wanted to mention that IFC has developed ethical principles in healthcare. I'm now sharing a link. You can become a signatory. Any hospital around the world can become a signatory for EPIC principles, ethical principles in healthcare. It's absolutely free of charge. And on the website, I have just shared the link in the chat. You can find all the information about it. Hopefully, it will help you to improve safety of their operations and also provide better care for your patients. And now let's move on to your questions. So basically, lots of questions arrived today. I don't even remember when we received that many questions during our webinars, which is great. And the first question is actually, who makes a decision about the necessity of blood transfusion? Several opinions, several questions arrived on this. Like, is it a practitioner? At what time the practitioner makes this decision? Is it the role of the blood transfusion committee, and how does it function in this case? Yeah, is it like always available, or maybe representatives are not available if it's an emergency situation? So who makes this decision and actually starts this process of blood transfusion preparation? Who would like to be the first?
Nadine, would you like to start?
Thanks, Manuel. So the decision always becomes the practitioner's decision. From my perspective, when informing that practitioner, there are many means by which we can educate the practitioner about the appropriate transfusion. The intent is to educate and advise, but not to force an individual to change a decision. And I think that is actually really helpful. And with time, practitioners do end up following criteria for transfusion. But so the short answer, it is the practitioner.
Thanks a lot. And the practitioner, Nadine, you mentioned we educate them. Who educates them? The lab or the blood transfusion committee, or whose role is to educate the practitioners?
So at our hospital, because we do have a transfusion medicine physician, the transfusion medicine physician takes the responsibility for education. But that can also come from the transfusion medicine committee or the transfusion medicine laboratory.
Thanks a lot. Yes, Manuel?
Well, there are also webinars or continuing education workshops available. In Canada, we have an organization that develops education for physician, nurses, lab technologies. So it is an effort. It comes from those places that have a transfusion medicine physician, that's true. But for those places that don't, I think we need to look for alternatives for webinars such as this one, or even the transfusion medicine committee, the chairman of the committee, or the team itself, looking after different references and books.
Thanks, Manuel. Yes, Titus, you wanted to comment on this topic?
Yes, thank you so much. The case is that when it comes to who make requests, who educate in our own setting, most of the time it is actually not, because blood transfusion community is not something that is widespread. It is with the advent of the collaboration of a private hospital with IFC that we now have blood transfusion committee. But physician managing his or her patient in our own setting, make a request, send to the lab. After making the diagnosis, maybe the patient's blood volume, maybe the platelets is low, the patient is bleeding, needs fresh frozen plasma, then make a request, send to the lab. The honor now lies on the laboratory physician to release blood to the ward for the patient to take. So, and it is the team, the medical team, that will actually transfuse the patient in question. That is my own.
Can I just add quickly? Can I just add quickly that if the physician orders blood or any blood component, the lab will know the standards and usually the guidelines for transfusion. The lab should have the knowledge to question sometimes some transfusions. And Nadine will know this, that the lab technology, usually a senior, will question why do you need 2 blood units if the hemoglobin is 80 or 90. So to some degree, the lab will be the first gatekeeper. And if not, then the transfusion medicine specialist in the hospital or somebody, a physician, a clinician, can be called to discuss the case with the MRP or the practitioner.
Thanks. That's very valuable point, Manuel, because I was going to say, let's once again clarify the roles of different participants, because this is something which might be very confusing. So what is the role of the officer and what is the role of the committee? Just briefly in like several points, like bullet points, what is the role? Because I would assume these notions will be very new to many of our audience. And just to make it right from the very beginning, what are the roles of these elements?
Okay, I'll have Nadine, do you want to start or you want?
I'm sure I can start. So from my perspective, the Transfusion Medicine Committee is there is an oversight for all transfusion practices in the hospital. They direct best practices for all transfusible products and for the process of transfusing. Medical laboratory technologist or the medical laboratory scientist is also responsible for the standard operating procedure, but also takes part in education. And as Manuel, and I'd like to highlight this as well, although I mentioned that it's the practitioner who orders, the transfusion medicine laboratory, the laboratory technologist, is also looking to determine that the criteria are being followed, to then approach the practitioner from an education perspective to ensure that they're following criteria. And if not, then they contact the transfusion medicine physician, for instance, if one occurs, to actually then educate the practitioner as well. The transfusion safety officer is sort of intermediary with the transfusion safety officer. So the medical laboratory, on a day-to-day basis, it's the medical laboratory technologists that are really taking the lead in transfusing or following, ensuring that adequate transfusion criteria are being followed. The Transfusion Medicine Committee essentially is an oversight committee, so meets 4 times a year. The transfusion safety officer is also there for day-to-day management. The transfusion medicine laboratory technologist is not going up to the ward, teaching nurses, or getting involved in that aspect of transfusion care with regards to ensuring specimens are taken appropriately, ensuring that transfusions are infused at appropriate rates, that transfusion reactions are being monitored for. It's really, that is the role of the transfusion safety officer as a liaison between the laboratory and clinical services.
Thanks,
Titus.
Nadine. This is very useful. Okay, Manuel?
I think Titus wanted to add a few words, and then I'll close.
Okay. Yes, Titus, please.
Okay, thank you so much. I love the perspective of Nadine, but then it is still like maybe more blood transfusion services is still at the infancy stage in our country, because as it stands in our setting, so most of the time the laboratory, the maybe blood transfusion committee, the laboratory staff, they don't really go to the ward. They don't really go to the ward. There are some indications where the hematologists come to the ward, maybe in the case of leukemia. So invariably, what I'm trying to say is that this person that still have the final say is still the health practitioner that is overseeing the patient, that is managing the patient, that knows the criteria for requesting for blood transfusion, that still take the priority. So most of the time, what we do in this part of the world, in Nigeria, so to say, is that once you make a request, then you make a request for grouping and cross-match, they check the patient's hemoglobin, then the people in the laboratory supply blood to the ward. But when it comes to monitoring of blood transfusion reaction, it's not yet there yet. We're not yet there yet.
Yeah, so
Thanks,
I think
thanks, Titus. Very practical tips you gave. That's always very useful. Yes, Manuel.
Thank you. So I think Titus raised a very important point. These transfusion medicine committees are more established in developed countries. In a survey made by WHO, only 30 to 40% of the countries will have a transfusion, hospitals will have worldwide, globally, of the hospital survey will have a transfusion medicine committee. So the purpose of today was actually bring to attention to the people, to the audience, that there are ways that we can use our own resources and tools to enhance patient safety and quality. One of them is to create a multidisciplinary committee. Another one that we're using, and is very popular now, and for Titus or for the audience in Africa and developing countries, is to have this figure of a transfusion safety officer. There are many other figures that you can have that you have in Canada, the person related to good practices when it comes to blood usage, utilization. There's another type of figures, but these are two good figures that we should start implementing, because they're very helpful. They're part of the standards, accreditation standards, and they will help you to liaison, and not only to liaison, but also will help you to investigate transfusion reactions. And this is a major component of the transfusion safety officer as well. The lab will do the testing in the lab, will check the sample, where the transfusion happened, but the transfusion safety officer, he usually is a nurse, it could be a lab technologist too, will go to the wards and will discuss the cases with physicians and mainly with nurses, and will check the charts. So these figures are becoming more popular, and today I'm happy to see that people are starting to get attention into this. Thanks.
Thanks a lot. Very, very important information about how to set up the capacity for safe blood transfusion. But also we received lots of questions on the specific how-tos. At what temperatures to store blood? Do we need to warm blood before transfusion? Compatibility, etc. So are there any useful resources and guidelines which are considered global best practices that our audience can refer to, can look up? And then use safely, that they are reliable. So maybe we can share these resources, because I'm not sure we can address all those very specific detailed questions today, but would be nice just to give clear guidance where to look.
Yes, so let me start this part, and then I'm going to pass it into Titus and Nadine, because this is a very important topic. There are standards and there are guidelines. WHO, CTSM, well, actually, kind of CTSM is also standards of practice for Canadians. AABB is another set of standards, but then you have WHO, you have guidelines that you can find on internet that from reputable organizations, and they will give you advice in terms of pre-analytical, analytical, and the administration piece. So there are many resources out there. Happy to share some of them. I don't know if we're going to do it now, or we can do it maybe in a follow-up email, or maybe within the video post presentation that we will set to the team. But there are many, because at the end of the end, what we need is we need to develop those standards of practice in our labs, in our hospitals, to ensure that everybody, like Nadine mentioned, people who are working the night shift, the weekend, when the resources are low, that they have access to standardized practice, they can follow the same procedure to ensure that the safety of the blood process is done in a proper way. Thank you. Any comments? Anything else to add to
Any other
that?
comments from our experts?
Yes, yes. As in, I have a comment here. So I have the opportunity most of the time to transfuse blood in the operating theater. Very many times when it comes to cardiothoracic surgery, you're doing a pneumonectomy, you're doing neurosurgery. So the way we do blood transfusion, when blood is coming from the blood bank, it's usually very, very cold. And as we all know, we know the temperature at which we store blood is usually very cold. And at that point in time, we don't give it to patient directly. Because as we all know, if we give a very cold blood to patient, saying that is not at room temperature, you know what can happen. It can actually shift the oxygen dissociation curve to the left. When oxygen dissociation curve is shifted to the left, that means the hemoglobin will bind avidly. We bind avidly to the oxygen. That is, there will not be release of oxygen peripherally, and invariably there may be tissue hypoxia. So what we do in my center is to put the blood under running water. You put the blood under running water until you ensure that the blood is not longer like an ice, or it's not that cold. At least must be in the room temperature. But then we don't put our blood inside hot water, because we put it under hot water, especially for platelets, it can get denatured. So what we do is to put it under running water, like about 30 minutes to under running tap, rather, in about 30 minutes to 1 hour. That means when you envisage that you are going to transfuse any patient with any unit of blood, that means you have to request for the blood from the blood bank in advance. It is not when the patient needs that blood that you actually request the blood. I'm talking about from the perspective of OR, that is the operating theater. But when it comes to the ward, in the ward, most of the time when patient needs blood, it's usually not an emergency. Blood transfusion in the ward, in the OR, is usually like an emergency, because you have to match the patient hemodynamics. But on the ward, most of the time, you have to just give to balance the patient hemodynamics. So that one is not an emergency. So once the blood gets to the ward, you put it under running tap. Maybe after 30 minutes or after an hour, you give to the patient. But it is not, we don't warm blood in our setting. We put it under running tap, so that, but then most importantly, that we don't give cold blood. Giving cold blood, we shift oxygen dissociation curve to the left, then preventing the release of oxygen to the tissues. Then invariably we will have tissue hypoxia. Thank you.
Thanks a lot, Titus. Nadine, any comments from you, or we move to another question?
We can move to another question. I think Manuel answered it.
The other question is actually a small hospital. Can they outsource the blood bank, especially if they have scope of services when it only needed in emergency situations? Or is it a must for every medical facility to have their own blood bank? What's the general rule for this?
I would say that every hospital should have their blood bank, especially when there are going to be acute situations where blood is going to be required emergently, and the processes and procedures have to be in place to ensure that it's the right product to the right patient.
Let me add to that, Nadine, because I've seen so many systems in Latin America and Africa. Yes, I agree with acute care patients and hospitals, but then you have these long-term facilities. You have small hospitals who may not be able to have a blood bank available in their facilities, but they should have a connection with another facility who can deliver the blood flows to them in a timely manner. They should look for that, and I've seen that that happens. Now in Canada, we have our model is that we have a blood collection center who processes the blood, who collects the blood and do the screening, and then ships the units to all the Canadian hospitals. In Africa, that's not the case. In Africa, for instance, if you go to Nigeria, if I'm not mistaken, if my memory doesn't fail, and Titus can corroborate on this, they don't have a national collection center, so they rely on hospitals having the blood itself, and that happens in multiple countries as well. So I think acute care, yes, ideally you should. If not, you need to look for an alternative to have that service available. I think I'd like to pass that question to Titus too, because he might answer from Africa as well.
Thanks, Manuel.
So we have National Collection Center. When it comes to blood transfusion, we have like two. We have one in Abuja and we have one in Owerri. And even Lagos right now has a National Collection Center, a state collection center where we distribute blood. Any blood that is collected from anywhere should get to a particular location in Lagos State where the blood is screened and verified before it's sent back to various hospitals. So we actually have two national collection centers, one in Abuja and one in Owerri. But now currently Lagos State has a collection center where all blood collected from all the sites, all the hospitals in Lagos will be moved, they will pull to that location, and then it will be rescreened and then we sent back to the hospital. So we now have it.
Thanks, Titus. That's very useful to know. Very useful model that you shared. And another question actually relates to the area of informed consent. Lots of questions on informed consent, and again, lots of details. So I'm not sure we can address, due to the lack of time, to go into all the details, but just what are the key safety tips regarding the informed consents that our audience, our hospitals need to remember. Example of the questions we received, should there be a separate informed consent for every blood transfusion, or can there be just one before the first one if several are needed? And also at what point it is collected, it is signed by the patient, and also maybe some other things that they need to keep in mind. A question to all our experts based on your experience.
Yep. So from my perspective, one consent form for transfusion is okay for all products. It also should highlight refusal of transfusions for those individuals that don't want blood for religious purposes. So that should also be on the consent form. All adverse events of transfusion should ideally be discussed. Now, obviously, different people who are going to be prescribers will not have that knowledge. And so that a transfusion consent form can be supplemented with, as I showed on one of the slides, education to the patient about the transfusion risk. So that way you're helping whoever is getting consent, which is usually the prescriber, ensure that the patient is aware of all the potential adversities, and they don't have to remember relaying it. It's on a separate brochure or pamphlet.
Thanks, Nadine. Manuel?
Titus.
Okay.
Whereas, thank you so much. Saying what Nadine just said is most of the time, Jehovah Witnesses saying that will refuse blood transfusion. So most of the time, once they refuse blood transfusion, then they have to come to the hospital, depending on why they are in the hospital. If they are coming in for surgery, then they have to come with a particular form, a specialized form, where we take a double and high risk consent, which they have to sign. And the form from their liaison committee that they will not take blood has to be signed. And we inform them of the implication. And most of the time, we also have a lot of processes, anesthetic technique and surgical technique in which we reduce blood loss at surgery. And in fact, we also give some fluid saying that is colored to boost, to balance, to improve the hemodynamics of patients at risk of a compromise, saying a surgery or on the ward, especially the Jehovah's Witness. I think that is what I have on that account.
Thanks a lot, Titus. Yes, Manuel.
Yeah, just quickly. I mean, in the assessment that I have done in multiple countries, I have noticed a variance of practice. So I've seen hospitals who use one concern form, a general concern form for treatments and invasive procedures, including and transfusion medicine as well. And I've seen hospitals who have multiple consent forms for anesthesiology, for transfusion, for surgery, for medications, for DI, so on. So I think at the end of the day, ideally, I'm going with Nadine. You should have a separate form for transfusion medicine. But the bottom line is that you need to discuss the risk, the benefits, and the risk of transfusion. So if you're going to put that together in one form and discuss and use one form to discuss all these things for surgery, for DI, for all the other procedures, then it's hard to keep that in mind. Plus, I will go with definitely having in this case for transfusion medicine, having one for all the different products that you're going to get, and also having that flyer to educate the patient as far as what are the risk benefits and the alternatives that you can have if you don't want to have blood in your body. Thank you.
Thanks a lot, Manuel. So we are actually running out of time. We will take just a couple more questions, and we are already staying longer than we planned. So thanks a lot for being with us. Also, I wanted to mention that questions which we couldn't cover today due to lack of time, we will likely to cover in our community of practice. So my colleagues will now share the link in the chat. It's on Facebook platform, and please feel free to join, to subscribe, and we will cover the highlights from today's webinars and address the most interesting questions which we didn't have time to address. One of the last questions that we wanted to cover today is actually again about useful resources. So we covered the consent forms. So lots of questions on compatibility. So compatibility of blood is one of them, or non-compatibility is one of the reasons for their adverse reactions after. So any tips you can give on this, any useful resources to look for the guidelines, how to build the internal procedure of checking to make sure that this is the compatible piece, and how to make sure that the team uses the right blood for the right patient, and any other advice that you can give in this regard.
Okay.
So, Julia.
Yeah, go ahead.
Sorry, Manuel, go ahead. I think Manuel there will be, we can post a lot of the accreditation criteria, and they can be incorporated into hospital standard operating procedures.
Yeah. So around compatibility testing, what you want to do is you want to match the donor blood with the recipient, right? You want to match those two. So there are lots of things that you have to keep in that process, the testing process, to ensure that the testing is done properly. And again, it's about resources. Like I said, I have seen many hospitals in different countries where they are limited resources, and they don't do the menu testing that we do in developing countries. So it's about how do we enhance that access? How do we provide tools to this to people who don't have the same access? For instance, I've seen countries that they only do ABO typing, they don't do reverse, they do only forward. I've seen countries that they don't do antibody screening. They only do ABO typing and the tube test. They don't do gel technology. So depending on where you go, so we're gonna provide resources and there are ways to do it properly to avoid transfusion reactions.
Thanks. Thanks a lot, Manuel. And also a question which was initially addressed to Titus and relates again to building a structure inside for safe transfusion inside the hospital. But I think also our other experts would have something to add. So Titus, do you have a quality team in your hospital? And in case you do, how the quality team participates in your work and how your safety transfusion committee interacts with the quality team? So how to build this interaction and this structure?
Yes, thank you so much. Right now in the hospital where I work is quite different from where I was trained. So when it comes to like quality and quality assurance, then there is a team that is fully on board right now. And in fact, then there is always, I think they are like monitoring team. If you don't do something, then they have contacts everywhere. If you don't do something to follow international guidelines and standard operating procedure, they have everyone on the ward, in the theater, in the ICU, to what they call them the whistleblower. Before you know it, they'll give you a call. Young man, what are you doing? There was a particular day that I was actually setting a central line. I think at that point in time, there was no gown. Before you know it, before I put in the central line, they called me. So right now, the quality team or the quality assurance team, they've gone far in my current center, that is Harry Jolad, to put in their own personnel in place on the ward, in the theater. If you are not doing things in the way it is being set up by the management of Harry Jolad, before you know it, a call is put across to you. So there is communication between, and in fact, once they put the call across to you, the first time, the second time, your brain should tell you that you should refrain from it. So in my hospital, we are involving, but then it's so impressive.
Thanks so much, Titus. Very useful to know. So Manuel, anything from you? And this was actually our last question for today because time is running so quickly.
No, Julia, I want to thank the audience, very active audience. I want to thank the panelists. Nadine, very insightful. Titus, it was great to stay with you. Julia, great moderator, and I look forward to sending more information and to connecting with the team and with the people of the audience as well. Thanks.
Thanks a lot, Manuel. So big thank you once again to all our speakers today, our experts, Titus, Manuel, Nadine, thanks a lot. Thanks a lot to active audience. I wanted once again to remind you that to get the certificate, if you were watching this on YouTube because you couldn't join Zoom for some reason because of the limitations of Zoom, please use the email. You can reply to in the invitation letter to this webinar or use the IFC Healthcare address, and send us your name so that we can, and email address, of course, so that we can send you a certificate of participation. So thanks a lot once again for everyone. It was an exciting discussion. I hope you found it useful. Also, those who watched this here in Zoom, please make sure you fill your name in the survey on exit. It's very, very important to get a certificate. So thanks a lot once again. Look forward to seeing you next time. We will advertise our next webinar topic, so please follow us and have a great day, afternoon, whatever it is, evening. Thanks a lot and bye-bye.
Thank you.
Thank you.